Welcome to the deep dive. We're here to plunge into complex subjects, really get to the heart of things, and give you the insights you need.
That's the goal. No surface scratching here.
Today, our mission is, well, fascinating. We're journeying into one of the most remarkable parts of your own body, the upper limb.
It really is incredible when you stop and think about it.
Absolutely. Just consider it for a second. This one limb does everything from, the super delicate work of threading a needle to the sheer power needed to throw a baseball or lift something heavy. It's just an amazing piece of biological engineering.
It really is. And by the end of this deep dive, our aim is for you to have a level of understanding that feels, well, truly professional. Like you've genuinely mastered this subject.
Yeah, we want you to feel that confident.
We're going to unpack the anatomy, the functions, the clinical side of things, shoulder, arm, forearm, hands, highlighting the key bits, how they connect, maybe some surprising facts along the way. Really elevate your understanding, give you that elite insight.
Okay, so if we're building this limb from the ground up, conceptually, where do we begin? How do anatomists break it down? It's not just one long piece, is it?
No, definitely not. It's an integrated system. We usually divide it into 4 main regions, each with its own job.
Right.
First up, you've got the shoulder. That's the crucial junction where the whole limb connects to your trunk.
Okay, the connection point.
Then moving down, you get the arm proper, that's from the shoulder down to your elbow joint. After the arm comes the forearm, running between the elbow and the wrist.
Okay.
And finally, the bit at the end, arguably the most complex part, the hand. Everything distal to the wrist. Each part specialized, but they all work together seamlessly.
And what's really interesting is how it connects to the trunk. You mentioned that connection point. It's different from our legs, isn't it?
Oh, vastly different. And that's fundamental to its function. Unlike our legs, which are built solid for support, for holding our weight.
Yeah.
The upper limb's main connection isn't rigid bone on bone. It's mostly muscular.
Mostly muscles holding it on. That sounds precarious.
It sounds it, but it's incredibly strong and crucially flexible. Think about it, this whole limb, capable of huge force, suspended primarily by an intricate web of muscles. There's only one small bony link, right where the clavicle, your collarbone, meets the sternum. That's the sternoclavicular joint.
It's just that one spot.
Just that one small joint. This muscular suspension is absolutely key. It gives us that amazing mobility at the shoulder, freedom of movement you just couldn't get otherwise. It's designed for reach, for manipulation, not static support.
That makes perfect sense. So if it's not mainly for support or walking like the legs, what is its primary job, its core purpose? It sounds like it really boils down to the hand.
Exactly. Positioning the hand in space. That's the mission.
Getting the hand where it needs to be.
Precisely. Every part of the upper limb, the shoulder's mobility, the elbow's hinge, the forearm's rotation, it's all geared towards placing that hand with incredible accuracy and control. And the hand itself. Well, it wears 2 hats, doesn't it?
2 main roles.
Yep. First, it's an amazing mechanical tool. Think about gripping, holding, manipulating objects. Usually that involves flexing your fingers against your thumb.
Right. Sure. Making a fist, grabbing things.
But it's way more sophisticated than just bending. You have these intrinsic muscles inside the hand itself. They're crucial. They don't just pull on their own. They fine-tune the actions of the longer tendons coming down from the forearm.
So the forearm gives the power, the hand gives the finesse.
In a way, yes. These intrinsic muscles allow for really complex, subtle movements within each finger joint. Delicate stuff. The kind of artistry you need for fine tasks, which the big forearm muscles alone couldn't manage. They enable those unique, precise movements we use constantly without even thinking.
And the second role, you said 2 hats.
The second role, equally vital, is as a sensory tool. It's not just what we do with our hands, but what we feel.
Touch.
Exactly. Discriminating textures, temperatures, shapes. It's phenomenal. And that's largely thanks to the incredibly high density of touch receptors packed into the pads of your fingers on the palm side.
That's why fingertips are so sensitive.
Precisely. And this sensory input is so critical for how we interact with the world that a disproportionately huge area of our brain's sensory cortex is dedicated just to processing information from the hand, especially the thumb.
More brain power for the hand than for, say, the whole back.
Absolutely. It highlights how important the hand is, not just for doing things, but for gathering information, for learning about our environment through touch. It's a primary data collector. Without that rich feedback, even simple movements would be clumsy.
Okay, so with all these structures, muscles, nerves, vessels running the length of the limb, especially down to the hand, there must be specific bottlenecks, right? transition zones where things pass through tight spaces?
Yes, definitely. There are three really significant transition zones, potential choke points, you could say.
Okay, what are they?
First is the axilla. Most people know it as the armpit. Anatomically, it's this sort of irregular pyramid-shaped space formed by shoulder muscles, bones, and the side of your chest wall. Its top opening, the apex, leads right up into the neck. The skin of the armpit is the floor.
And why is it so important?
Because basically everything major going between the neck and the arm has to pass through it. The brachial plexus nerves, the main axillary artery and vein, lymph vessels, they all travel through the axilla. It's a protected pathway, but also a place where compression can happen if there's swelling or injury.
Right, a central hub. Okay, what's next? Moving down.
Moving down to the elbow, on the front side, you find the cubital fossa.
Cubital fossa?
Yeah, it's that triangular depression you see or feel in front of your elbow bounded by muscles, another critical passageway.
What goes through there?
Two key things. The brachial artery, which is the main blood supply continuing down to the forearm, and the median nerve, one of the limb's most important nerves. Clinically, it's super important where you often take a pulse, draw blood from the vein running over it.
Okay. That makes sense.
Understanding its contents and boundaries is, well, pretty fundamental for healthcare professionals.
And the third one, a name many people might recognize, carpal tunnel.
That's the one. The carpal tunnel is literally the gateway to the palm. It's formed by an arch of the small carpal bones at the wrist, and then a really thick band of connected tissue, the flexor retinaculum, stretches across that arch, forming the roof or the anterior wall of the tunnel.
And it's a tight space.
Very tight. And through this tunnel, past the median nerve, and all 9 of the long flexor tendons going to your fingers and thumb.
9 tendons plus the nerve. Wow.
Exactly. Which is why it's so clinically relevant. Any swelling in there, any inflammation, can easily compress that median nerve, leading to carpal tunnel syndrome, which can really impact hand function.
Okay, that's a fantastic overview of the general plan, the function. Now let's dig into the architecture itself. The bones, the joints, the physical structure. Starting at the top, the shoulder girdle. You said it's built for mobility?
That's its hallmark. And it starts with the clavicle, the collarbone. It seems quite slender, but it's incredibly important. It's the only actual bony connection between your entire upper limb and the main trunk of your body.
Really? Just the collarbone?
That's it. You can feel its whole length, that gentle S shape. It curves forward medially near your sternum and backward laterally where it meets the scapula. The inner end, the sternal end, is thicker, more robust, and it connects to the sternum's manubrium and the first rib cartilage. The outer acromial end is flatter and links up with the scapula.
And it has specific bumps or markings?
Yes. Underneath, especially in the lateral part, there are important markings. The conoid tubercle and the trapezoid line. These are attachment points for the very strong coracocclavicular ligament.
Coracocclavicular?
Yeah, it's a crucial ligament that anchors a clavicle to a part of the scapula called the coracoid process. It basically stops the scapula from popping up and helps suspend the weight of the arm from the clavicle.
Got it, so vital strut. Then there's the scapula, the shoulder blade. It sounds complicated. Angles, borders, processes.
It is quite complex, but its complexity serves its function as the mobile base for the arm. Think of it as a large, flat, triangular bone gliding over your rib cage.
Triangular.
Yeah, 3 angles, lateral, superior, inferior. 3 borders, superior, lateral, medial. But the key features are really about attachment and articulation. The lateral angle has the glenoid cavity.
That's the socket for the arm bone?
Exactly. But it's very shallow. Think like a golf ball on a very flat tee. Great for movement, but not inherently stable.
Needs muscle support.
Definitely. Above and below the glenoid cavity are little bumps, the supraglenoid and infraglenoid tubercles, where the biceps and triceps tendons attach. On the back surface, there's a prominent spine.
You can feel that on your back.
It divides the back into 2 fossa, or depressions supraspinous and infraspinous. This spine extends outwards to become the acromion, which forms the bony roof over the shoulder joint, and attachment. And then there's the coracoid process, this sort of hook-like projection pointing forwards. It's another really important anchor point for muscles and ligaments, adding stability.
So it's a very functional shape. And then the arm bone itself, the humerus connecting to the scapula. Let's talk about the top part, the proximal humerus.
Right. The proximal humerus starts with the head, that smooth, half-circle part that fits into the glenoid cavity. It points medially and a bit upwards. Just below the head is the anatomical neck. And then you get 2 really important bumps. The greater tubercle laterally and the lesser tubercle anteriorly.
Tubercles, attachments.
Key attachments for the rotator cuff muscles. The greater tubercle has 3 smooth facets on top for the supraspinatus, infraspinatus, and teres minor muscles. The lesser tubercle has a spot for the subscapularis.
So all 4 rotator cuff muscles attach right there.
Right around the head, yeah. Between these 2 tubercles is a groove, the intertubercular sulcus, or a bicipital groove.
Bicipital for the biceps.
Exactly. The long tendon of the biceps muscle runs right through this groove. And the edges of the groove, the lips, are also important attachment sites for big muscles like pectoralis major, teres major, latissimus dorsi.
Lots going on there.
And a bit further down the shaft, laterally, is a rough V-shaped area, the deltoid tuberosity, for the powerful deltoid muscle. And we can't forget the surgical neck.
Surgical neck, not the anatomical neck.
No, it's a bit lower, just below the tubercles. It's a common spot for fractures because the bone narrows there. And crucially, the axillary nerve wraps right around it. Very important clinically.
Definitely. Okay, so those are the bones. Let's connect them with the actual joints of the shoulder complex, the functional units. Starting medially, the sternoclavicular joint.
The sternoclavicular joint, it's where the clavicle meets the sternum and the first rib cartilage. It's a synovial joint, technically saddle-shaped.
Saddle-shaped.
Yeah, which allows for quite a bit of movement. What's interesting is it has an articular disc inside, completely dividing the joint cavity, like a little cushion. This allows movement in multiple directions, forwards, backwards, up, down, and even some rotation of the clavicle. It's surprisingly mobile for being the main bony anchor. And it's reinforced by strong ligaments, sternoclavicular ligaments, front and back, and the costoclavicular ligament anchoring it down to the first rib. It's strong despite the movement.
Got it. Then, moving laterally, where the clavicle meets the scapula, the acromioclavicular joint.
The acromioclavicular, or AC joint, a much smaller synovial joint, more of a gliding type, between the acromion of the scapula and the lateral end of the clavicle.
Gliding.
Allows for some subtle adjustments, anteroposterior, vertical movements, and some rotation of the scapula relative to the clavicle. It has its own small acromioclavicular ligament on top. But the real stability here comes from that coracoclavicular ligament we mentioned earlier.
The one attaching underneath.
Yes, that super strong ligament running from the coracoid process of the scapula up to the clavicle. It's actually 2 parts, trapezoid and conoid ligaments. It provides the main weight-bearing support for the arm on the clavicle and keeps the clavicle locked down onto the acromion. If that pairs badly, you get a shoulder separation.
Okay, so that ligament is key. Now for the main event, the glenohumeral joint, the shoulder joint proper, famous for its mobility, maybe infamous for its instability.
That's the perfect way to put it. The glenohumeral joint is the classic ball and socket joint. Unmatched range of motion, flexion, extension, abduction, adduction, rotation, circumduction, everything.
But the trade-off?
The trade-off is bony stability. That humeral head is large, the glenoid socket is small and shallow. Again, think golf ball on a tee. It relies heavily on soft tissues to stay put.
So what holds it together?
It's a combination. Primarily the rotator cuff muscles dynamically compressing the head into the socket. Also, the long head of the biceps tendon helps superiorly. The bony processes like the acromion and coracoid process provide some structural support. And then there are ligaments.
Okay. And the socket itself. Is there anything to make it deeper?
Yes, the glenoid labrum. It's a fibrocartilage rim attached around the edge of the glenoid cavity. It acts like a bumper, effectively deepening the socket a bit, increasing the contact area and making it more stable. The biceps tendon also attaches to it superiorly.
Okay. And the joint capsule, the lining.
There's a fibrous joint capsule that attaches around the glenoid margin into the anatomical neck of the humerus. It's relatively thin, but interestingly, it's quite loose, especially underneath.
Loose? Why?
To allow for full abduction, lifting your arm way up. If it were tight, it would restrict that movement. This redundancy allows the range. Inside that is the synovial membrane, which produces the joint fluid. It also bulges out to form bursae.
Bursae, like little fluid sacs.
Exactly. Like the subtendinous bursa of subscapularis, which communicates with the joint. And others nearby, like the big subacromial subdeltoid bursa, which don't communicate but are vital for reducing friction between tendons, muscles, and bone during movement.
Got it. And the ligaments specifically strengthening the capsule. And the rotator cuff again.
Right. The fibrous capsule itself has thickenings that form distinct ligaments. There are the glenohumeral ligaments, superior, middle, and inferior, mostly on the front. There's the strong coracohumeral ligament on top, running from the coracoid process to the tubercles. And the small transverse humeral ligament, which cleverly bridges the gap over the bicipital groove, holding that biceps tendon securely in place.
Like a little strap.
Exactly. And then blending intimately with this capsule, you have the tendons of the four rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. They form this dynamic musculotendinous cuff or collar all around the joint, constantly working to stabilize the humeral head, pulling it snugly into the glenoid. It's a beautiful system of dynamic stability.
And it needs a good blood supply and nerve connection, I assume.
Absolutely. Blood supply comes mainly from branches of the anterior and posterior circumflex humeral arteries and the suprascapular artery. Good flow for a very active joint. Innervation is from branches of the brachial plexus, suprascapular, axillary, and lateral pectoral nerves primarily, highly integrated.
Okay, fascinating complex. Moving down the limb now, the bones of the arm, forearm, and hand. The lever system, the humerus, continues down from the shoulder.
Yes, the humerus is the single bone of the arm. Its shaft below the surgical neck is roughly triangular in cross-section. An important feature on the back is the radial groove.
Radial groove for the radial nerve.
Precisely. The radial nerve and the deep brachial artery spiral around the bone in this shallow groove. That's why mid-shaft humerus fractures are notorious for causing radial nerve damage.
Okay. Vulnerable spot.
Very. Then, the distal end of the humerus flattens out and forms the elbow joint articulation. You have the condyle, which has two parts, the rounded capitulum laterally for the radius, and the pulley-shaped trochlea medially for the ulna.
Capitulum and trochlea.
Flanking, these are the epicondyles. The medial epicondyle is that prominent bump on the inside of your elbow. It's the attachment point for most forearm flexor muscles, and crucially, the ulnar nerve passes right behind it.
The funny bone.
That's the spot. The lateral epicondyle is smaller on the outside, and it's the attachment for most forearm extensor muscles. Above the condyle, there are three depressions, or fossa radial, coronoid, and olecranon, which accommodate parts of the radius and ulna during full bending and straightening of the elbow.
So the bones fit snugly at the extremes of motion. Now the radius and ulna in the forearm, two bones parallel. Their relationship seems key.
It's absolutely key for pronation and supination, turning your palm up and down. The radius is the lateral bone on the thumb side. It's interesting because it's small at the top, where its disc-shaped head meets the humerus and ulna, but it gets much bigger and wider at the bottom, where it forms the main part of the wrist joint. Just below the head is the radial tuberosity, a bump, where the biceps tendon attaches powerfully.
Okay. Radius lateral, small top, big bottom, and the ulna.
The ulna is medial, on the pinky side, and it's the opposite. It's large and robust proximally, forming the main hinge of the elbow. It has the big olecranon process, the bony point of your elbow you lean on, and the coronoid process sticking forwards. Between them is the deep trochlear notch that grabs onto the humerus's trochlea. It also has a little radial knock on the side where the head of the radius fits. The ulna then tapers down to a small head and a little point, the ulnar styloid process, at the wrist.
So ulna medial, big top, small bottom.
Exactly. Both bone shafts are roughly triangular, with sharp interosseous borders facing each other, where the strong interosseous membrane connects them. And distally, the radius has that dorsal tubercle on the back, acting as a pulley for a thumb tendon, and its radial styloid process sticks down further than the ulnas. This whole setup allows the radius to pivot around the ulna for those crucial rotation movements.
Makes sense. Now, the bones of the hand. So many small parts for dexterity.
Incredible complexity for incredible function. You start with the 8 small carpal bones in the wrist, arranged in 2 rows.
2 rows of 4.
Yep. The proximal row, from thumb side to pinky side, is scaphoid, lunate, triquetrum, pisiform. The pisiform is tiny, sits on the triquetrum.
Scaphoid, lunate, triquetrum, pisiform. Okay.
Distal row, again thumb side to pinky side. Trapezium, trapezoid, capitate, hamate. The hamate has a distinctive hook.
Trapezium, trapezoid, capitate, hamate. Got it. 8 carpals.
These little bones glide slightly against each other, allowing wrist flexibility. Together, they form the carpal arch, concave on the palm side. The sides of this arch are formed by bumps on the scaphoid and trapezium laterally, and the pisiform and hook of the hamate medially.
And that arch forms the base of the carpal tunnel.
Exactly. The flexed retinaculum spans across it, enclosing the tunnel. Then you have the 5 metacarpals, numbered I to V, thumb to pinky, forming the skeleton of your palm.
Metacarpal eye for the thumb. That's special, right?
Very special. It forms a saddle joint with trapezium. This unique joint allows the thumb its amazing mobility, flexion, extension, abduction, adduction, rotation, opposition. Absolutely key for grasping.
And the other metacarpals?
2 through V have much more limited movement at their bases where they meet the carpals, just some gliding. Metacarpal V has the most movement, letting you cup your hand. Importantly, the heads of metacarpals 2 to V are linked together on the palmar side by the deep transverse metacarpal ligaments.
Holding the palm together.
Yes, creating a unified structure. But significantly, this ligament doesn't connect the thumb metacarpal to the index finger metacarpal. That gap is crucial for the thumb's freedom.
Ah, clever design. And finally, the fingers.
The phalanges. These are the bones of the digits themselves. The thumb, digit I, has 2, a proximal and a distal phalanx. The other 4 fingers, digits I, ABV, each have 3, proximal, middle, and distal phalanges. Simple hinge joints between them.
Okay, that lays out the whole bony framework. Now let's look at the joints of the forearm and hand in a bit more detail. We touched on the elbow joint. You said 3 articulations in one.
That's right. The elbow is complex. It shares one joint capsule, but involves 3 distinct bony interactions.
Okay.
You have the humero-ulnar joint, the main hinge between the ulna's trochlear notch and the humerus's trochlea. That's for flexion and extension. Then the humero-radial joint between the radial head and the humerus's capitulum, which also contributes to flexion extension but is vital for rotation. And finally, the proximal radial-ulnar joint between the radial head and the ulna's radial notch. This one is all about pronation and supination.
So hinge movement and rotation happening side by side.
Exactly. All covered in smooth, hyaline cartilage. The synovial membrane lines everything, with fat pads cushioning the fossa. The fibrous capsule is strong, reinforced by powerful medial and lateral collateral ligaments that prevent side-to-side wobble, and crucially, the annular ligament wraps around the radial head like a collar, holding it against the ulna while allowing it to spin freely during pronation-supination. It's a really elegant design.
Very neat. And the connection at the other end, the distal radial ulnar joint.
Also essential for rotation. This is down at the wrist, between the small head of the ulna and the ulnar notch on the big distal radius. There's also a key articular disc, a triangular piece of fibrocartilage.
A disc here too.
Yes, and it's important because it separates the ulna from directly contacting the carpal bones in the main wrist joint. It bears load and stabilizes the joint while allowing the radius to swing around the ulna during pronation and supination.
Yeah.
It lets the distal radius cross over the ulna.
Okay. And connecting the shafts of these 2 bones?
That's the interosseous membrane, a strong fibrous sheet running between the interosseous borders of the radius and ulna. Its fibers mostly run downwards from radius to ulna.
Why that direction?
It's perfect for transmitting force. When you push up through your hand, the force goes mainly to the radius, since it forms the wrist joint, and this membrane pulls that force across to the ulna, distributing the load up the forearm more evenly towards the humerus. It also provides a huge surface area for muscle attachments, but it's flexible enough to allow the twisting of pronation-supination.
Clever. So the actual wrist joint itself, the radiocarpal joint, where the forearm meets the hand.
Right. This is a synovial joint between the large distal end of the radius and that articular disc covering the ulna on one side, and the proximal row of carpal bones, specifically the scaphoid, lunate, and trichotrum on the other. The carpals form a convex surface fitting into the concave radius disc.
What movements happen here?
It's biaxial, allowing flexion, extension, abduction, radial deviation, and adduction, ulnar deviation, plus circumduction. You'll notice you can adduct, bend towards pinky, more than abduct, bend towards thumb.
Why is that?
Because the radial styloid process sticks down further than the ulnar styloid, creating a bony block on the radial side.
Makes sense. Then into the hand proper, the carpometacarpal joints.
The carpometacarpal CMC joints connect the distal row of carpals to the bases of the 5 metacarpals. The thumb's CMC joint is the star here.
The saddle joints?
Exactly, between metacarpal and the trapezium. That saddle shape allows the thumb its incredible range, flexion, extension, abduction, adduction, rotation, opposition. It's what makes our thumb so useful.
And the others?
The CMC joints for fingers 2 to V are much less mobile, mainly just slight gliding movements, allowing the palm to cup slightly. Mobility increases a bit from the index finger towards the pinky.
Okay. Next up, the knuckles, the metacarpophalangeal joints.
The metacarpophalangeal MCP joints. These connect the heads of the metacarpals to the bases of the proximal phalanges. They're condylar joints.
Condylar, meaning?
They allow movement in 2 main planes. Flexion extension, bending and straightening the finger at the knuckle, and abduction adduction, spreading fingers apart and bringing them together. Also circumduction. They have strong palmar ligaments and collateral ligaments on the sides for stability.
Got it. And finally, within the fingers themselves.
The interphalangeal IP joints, these are the joints between the phalanges. The thumb has 1 IT joint, fingers 2 IV each have 2, a proximal IP, PIP joint, and a distal IP, DIP joint.
And these are simple hinges.
Pure hinge joints. Only allow flexion and extension, bending and straightening the segments of your fingers. Again, strong collateral ligaments on the sides prevent any wobble.
Okay. And one last ligament system you mentioned earlier, linking the metacarpal heads.
Right, the deep transverse metacarpal ligaments. These are strong bands that connect the palmar ligaments of the MCP joints of figures 2, 3, 4, and V. They essentially tie the heads of these four metacarpals together, limiting their independent movement and creating a stable, unified palm structure.
But not the thumb.
Critically, not the thumb. The absence of this ligament between the thumb, metacarpal 1, and the index finger, metacarpal 2, is a major reason why the thumb has such freedom to move independently and oppose the other fingers.
All right, we've built the scaffold, the bones and joints. Now let's add the power and control, the muscles and tendons that make it all move. Starting back at the muscles of the shoulder, you mentioned superficial and deep layers.
Yeah, broadly speaking, the superficial muscles are the large ones that shape the shoulder and produce big movements, primarily the trapezius and the deltoid.
Trapezius, the big one on the upper back and neck.
That's it. A huge diamond-shaped muscle connecting the scapula and clavicle to the spine and skull. It does a lot. Elevates the scapula, shrugging, rotates it upwards when you raise your arm high, retracts it, pulls shoulder blades together, even depresses the lower part. Really important for scapular positioning.
And the deltoid.
The deltoid is the thick, triangular muscle that forms the rounded cap of your shoulder. It attaches the clavicle and scapula to the humerus. Its main job is abducting the arm, lifting it out to the side, especially after the first 15 degrees or so. But its front fibers help flex the arm, and its back fibers help extend it. A real powerhouse.
Okay, and beneath these, the deep muscles.
Deep to the trapezius, you have muscles that primarily control the scapula's position against the rib cage. The levator scapulae, running from the neck down to the top corner of the scapula, does what its name says, elevates the scapula. Then you have the rhomboid minor and rhomboid major, running from the spine to the medial border of the scapula. They work together to elevate and retract the scapula, pulling it upwards and inwards towards the spine. They stabilize the base.
Got it. And then the really crucial ones for the joint itself, the rotator cuff muscles.
Absolutely critical. These four muscles are the dynamic stabilizers of the glenohumeral joint. They originate on the scapula, and their tendons wrap around the humeral head, blending with the joint capsule.
Four of them. What are they and what do they do?
Okay. Supraspinatus sits in the supraspinous fossa, above the scapular spine. Its key role is initiating abduction the first 15 degrees of lifting your arm sideways.
Just the start.
Yeah. Then the deltoid takes over for power. Then infraspinatus, in the infraspinous fossa below the spine, and teres minor just below that, are the main lateral rotators. They turn your arm outwards.
Okay, outward rotation.
And finally, subscapularis, which sits on the front surface of the scapula against the ribs. It's the primary medial rotator turning your arm inwards. Together, they actively pull the humeral head into the shallow glenoid socket, keeping it centered and stable throughout movement. They're vital.
Vital and often injured, I hear.
Very common site of injury, yes. Tendinitis, tears, because they work so hard in that tight space.
Okay, moving down to the muscles of the arm. Primarily controlling the elbow, right? Two compartments again.
Yes, an anterior flexor compartment and a posterior extensor compartment. Nice and logical.
Let's start with the anterior flexor compartment, biceps territory.
Definitely. The muscles here are all innervated by the musculocutaneous nerve. You have the coracobrachialis, a smaller muscle running from the coracoid process to the humerus. It helps flex and adduct the arm at the shoulder. Then the famous biceps brachii.
Two heads, right.
Yep, a long head and a short head. It's a powerful flexor of the forearm at the elbow, but it's also a very powerful supinator, especially when the elbow is bent. Think turning a screw.
The twisting motion.
Exactly. The long head also helps flex the shoulder slightly and stabilizes the humeral head. Deep to the biceps is the brachialis. This is the workhorse of elbow flexion. Attaches directly to the ulna, purely flexes the forearm. Very strong.
So biceps flexes and supinates, brachialis just flexes.
You got it. Coracobrachialis helps at the shoulder.
Okay. And the posterior extensor compartment, straightening the arm.
Simple here. Just one muscle, the triceps brachii. All innervated by the radial nerve.
Three heads.
Yes. Long, lateral, and medial heads. They all converge onto the olecranon process of the ulna. Its main job is powerful extension of the forearm, straighten the elbow. The long head, because it originates from the scapula, can also help extend and adduct the humerus at the shoulder.
Triceps extends the elbow. Got it. Now, things get more complex as we move into the muscles of the forearm, controlling the wrist, fingers, and that pronation supination.
Definitely more crowded here. Again, we have an anterior flexor compartment and a posterior extensor compartment.
Let's tackle the anterior flexor compartment first. Lots of layers.
Yes, typically grouped into 3 layers: superficial, intermediate, and deep. The innervation here is mostly the median nerve, but with 2 important exceptions supplied by the ulnar nerve.
Okay, layer by layer. Superficial layer.
4 muscles originating mainly from the medial epicondyle, from lateral to medial. Pronator teres helps pronate the forearm and flex the elbow. Flexor carpi radialis flexes and abducts, radial deviates the wrist. Its tendon is your landmark for the radial pulse. Palmaris longus, a weak wrist flexor that tenses the palmar fascia. It's famously absent in about 15% of people.
Really? Absent?
Yep, you can check yourself, touch thumb to pinky, and flex your wrist slightly. If you see a tendon pop up in the middle, you have it. If not, you're in the 15%. It doesn't really affect function.
Huh. Okay. And the fourth superficial one?
Flexor carpi ulnaris. This is the first ulnar nerve muscle. It powerfully flexes and adducts, ulnar deviates the wrist.
Got it. Superficial layer done. Intermediate layer.
Just one muscle here, but it's a big one. Flexor digitorum superficialis, FDS. It originates broadly from the humerus, ulna, and radius. Its 4 tendons go to fingers tie IV, splitting to attach to the middle phalanges. It flexes the middle and proximal joints of the fingers and also the wrist. Still median nerve.
FDS for the middle joints.
Okay.
And the deep layer.
3 muscles here. Flexor digitorum profundus, FDP. This lies deep to FDS. Its tendons go all the way to the distal phalanges of fingers TA. It's the only muscle that can flex that last joint.
The fingertip bend.
Exactly. Now, FDP is interesting because its medial half, for ring and little fingers, is innervated by the ulnar nerve. That's the second ulnar exception. The lateral half, for index and middle fingers, is median nerve, specifically its anterior interosseous branch.
Dual innervation. Okay. What else in the deep layer?
Flexor plexus longus, FPL. This is the dedicated long flexor for the thumb, flexing its distal phalanx. Essential for strong pinch grip. Innervated by the anterior interosseous nerve, for median. And finally, pronator quadratus, a small square muscle deep down at the wrist, running between radius and ulna. It's the primary pronator of the forearm, also anterior interosseous nerve.
Pronator quadratus, the main pronator, not pronator teres.
Teres initiates and assists, especially with speed or resistance, but quadratus is the prime mover for pure pronation, pulling the distal radius over the ulna.
Okay, that's a lot of flexors and pronators. Now let's flip to the back. The posterior extensor compartment of the forearm. Extension and supination.
Right, and these are pretty much all innervated by the radial nerve or its branches, like the posterior interosseous nerve. Again, we have layers.
Superficial layer first.
Okay. Starting laterally, there's brachioradialis. It's anatomically in the posterior compartment, but functionally it's an elbow flexor, especially when your forearm is halfway between pronation and supination, like a hammer curl position.
Interesting. A flexor in the extensor compartment.
Bit of an anomaly, yeah. Then you have the wrist extensors, extensor carpi radialis longus and extensor carpi radialis brevis, ECRL and ECRB, both extending and abducting the wrist. Then extensor digitorum, the main finger extensor, sending pendants to the back of fingers TIV to straighten them. Extensor digiti minimi, a dedicated extensor for the little finger. And extensor carpi ulnaris, ECU, which extends and adducts the wrist. Finally, the tiny anconeus at the elbow, which helps the triceps extend the elbow and stabilizes it during pronation.
Got the superficials, now the deep layer of extensors, more refined movements.
Exactly, especially for the thumb and index finger plus supination. 5 muscles here, mostly innervated by the posterior interosseous nerve. Supinator wraps around the proximal radius and does exactly what its name says, supinates the forearm, turning the palm up. Then you have 3 thumb muscles forming the anatomical snuff box borders. Abductor pollicis longus, APL, which abducts the thumb at the CMC joint. Extensor pollicis brevis, EPB, extending the thumb's MCP and CMC joints. And extensor pollicis longus, EPL, extending all the thumb joints, including the tip. EPL's tendon hooks around that dorsal tubercle on the radius.
APL, EPB, EPL, the snuff box muscles.
Okay, and the last deep muscle is extensor indicis, which gives independent extension to the index finger, allowing you to point.
So you can point even if the main extensor digitorum is held back.
Exactly. Provides that extra control.
Wow, the forearm is packed. Now finally, the muscles of the hand itself, the intrinsic muscles. These must be for the really fine stuff.
Absolutely.
Yeah.
Forearm muscles provide the power grip. The intrinsic hand muscles provide the precision, the delicate movements, tiny adjustments, complex coordination.
And the innervation is mostly?
Predominantly the deep branch of the ulnar nerve. The big exceptions are the thenar muscles at the base of the thumb and the 2 lateral lumbricals, which get the median nerve. This pattern is clinically very important.
Okay, let's run through them. There's one called palmaris brevis.
Yeah, it's a funny little one. Small, thin muscle just under the skin on the pinky side of the palm. It attaches to the skin. Its job is basically to wrinkle the skin there and slightly deepen the cup of the palm, maybe helping grip. Ulnar nerve innervation.
Okay. Then the interossei, between the bones.
Yes, the interossei muscles, located between the metacarpals, key for finger spreading and closing. There are 4 dorsal interossei on the back, which abduct the fingers, spread them apart, remembering DAB, dorsal abduct, and 3 or 4 palmar interossei on the front, which adduct the fingers, bring them together, remembering PAD, palmar adduct.
DAB and PD. Nice mnemonic.
They also help flex the MCP joints and extend the IP joints via the extensor hoods, all innervated by the ulnar nerve.
And the adductor pollicis. Sounds important for grip.
Hugely important. A large, powerful muscle deep in the palm that pulls the thumb forcefully towards the palm. Essential for strong gripping and pinching. Also ulnar nerve.
Okay. Now those fleshy mounds in the palm, the thenar and hypothenar eminences.
Right. The thenar muscles form that bulge at the base of your thumb. The thenar eminence. 3 key muscles here, all crucial for thumb opposition and movement, and importantly, innervated by the recurrent branch of the median nerve.
Median nerve here. Which muscles?
Opponens pollicis, the deepest one, rotates the thumb metacarpal to bring the thumb pad across to oppose the fingertips. Abductor pollicis brevis, APB, the most superficial, abducts the thumb away from the palm. And flexor pollicis brevis, FPB, flexes the thumb's MCP joint. APB and opponents are key functions, lost early in carpal tunnel syndrome.
Got it. And the other side, the pinky side mound.
That's the hypothenar eminence, formed by the hypothenar muscles at the base of the little finger. Mirroring the thumb side, you have opponens digiti minimi, which helps cup the palm by rotating the 5th metacarpal. Abductor digiti minimi, which pulls the little finger away from the ring finger. And flexor digiti minimi brevis, which flexes the little finger's MCP joint. All 3 hypothenar muscles are innervated by the ulnar nerve.
Thenar, inves, median, hypothenar, ulnar. Okay. And those unique lumbricals. Worm-like.
Yes, the lumbricals are fascinating. 4 small muscles. They don't originate from bone, but from the tendons of the flexor digitorum profundus in the palm.
Arising from tendons. Weird.
Unique. They then pass to the thumb side of each finger and insert onto the extensor hoods on the back. The 2 medial ones, for ring and little fingers, are ulnar nerve. The 2 lateral ones, for index and middle, are median nerve.
And their action is paradoxical?
Sort of. Because of their attachment to the extensor hood, they flex the metacarpophalangeal MCP joints, but extend the interphalangeal IP joints, that bye-bye or ta-ta motion, essential for fine motor control, like writing.
Flex the knuckles, straighten the fingers. Got it. You can't do that smoothly with just the long forearm tendons.
Okay, and lastly, for muscle tendons, you mentioned extensor hoods and fibrous digital sheaths. These sound important for keeping everything working smoothly.
Absolutely crucial plumbing, you might say. The fibrous digital sheaths are strong tunnels on the palmar side of the fingers, made of arches and crisscross ligaments. They strap the flexor tendons tightly against the phalanges.
Why is that important?
It prevents the tendons from bowstringing away from the bone when you bend your finger. Without them, flexion would be weak and inefficient. Inside these sheaths are synovial sheaths, providing lubrication for smooth gliding.
Like conduits. And the extensor hoods.
These are complex, triangular expansions of the extensor tendons on the back of the fingers, over the MCP and proximal phalanges. The extensor tendon flattens out, and importantly, the tendons of the lumbricals and interossei insert into the sides of these hoods.
So the intrinsics join the extensors here. Exactly. This clever arrangement allows the intrinsic muscles, lumbricals and interossei, to help extend the IP joints while simultaneously flexing the MCP joints. It's how they achieve that coordinated ta-ta movement. It's a beautiful piece of biomechanical engineering integrating multiple muscle actions.
All right, we've got the structure, the movers. Now for the control system. The nerves of the upper limb. This sounds like a complex wiring diagram, starting with the famous brachial plexus.
It is indeed a complex hub. The brachial plexus is this intricate network of nerves formed by the anterior, the front branches of spinal nerve, C5, C6, C7, C8, and the first thoracic nerve, T1.
C5 to T1, where is it located?
It actually starts up in the neck, deep between the scalene muscles. Then it passes down over the first rib through what's called the axillary inlet and into the axilla, the armpit. From there, its major branches spread out to supply motor control and sensation to the entire upper limb, shoulder, arm, forearm, hand. Understanding its layout is absolutely key clinically.
It sounds like it starts as separate nerves and then mixes together. Can you walk us through the structure? Roots, trunks.
Exactly. It's organized in stages. Think Randy Travis drinks cold beer. Roots, trunks, divisions, cords, branches, the terminal nerves.
Okay, RTDCB. Let's start with our roots.
Roots are simply those anterior rami of C5, C6, C7, C8, and T1 as they emerge from the spine.
T-trunks.
The roots quickly merge to form three trunks in the lower neck. The superior trunk from C5 and C6 roots, the middle trunk from the C7 root alone, and the inferior trunk from C8 and T1 roots.
D divisions.
Each of the three trunks then splits into two divisions as they pass behind the clavicle. An anterior division and a posterior division, so 6 divisions in total. This is where the sorting really happens.
Sorting for front and back of the limb.
Basically, yes. The anterior divisions generally supply nerves for the anterior flexor compartments of the arm and forearm. The posterior divisions supply nerves for the posterior extensor compartments. No major nerves come directly off the divisions themselves. It's a reorganization step. The 6 divisions then recombine in the axilla to form 3 cords, which are named based on their relationship to the axillary artery, which runs right through the middle of them.
Named relative to the artery.
Okay, you have the lateral cord, lying lateral to the artery, formed by the anterior divisions of the superior and middle trunks, carrying C5, C6, C7 fibers. The medial cord, medial to the artery, formed from the anterior division of the inferior trunk, C8, T1 fibers, and the posterior cord, posterior to the artery, formed by the union of all 3 posterior divisions, carrying fibers from all roots, C5, T1.
Lateral, medial, posterior cords, and B branches.
Finally, these cords give rise to the major branches, the main peripheral nerves of the upper limb. This whole mixing and rearranging ensure that most peripheral nerves contain fibers from multiple spinal cord levels, allowing for complex, coordinated function and providing some backup if one root is damaged.
Incredible organization. And specific nerves come off at different points along this pathway, right? Giving specific innervations.
Exactly. Even before the cords, some nerves branch off. From the roots, the dorsal scapular nerve to rhomboids, levator scapulae, and the crucial long thoracic nerve to serratus anterior damage causes wing of scapula.
On the trunks.
Mainly the suprascapular nerve from the superior trunk to supraspinatus, infraspinatus, and the small nerve to subclavius.
Okay, now the cords give rise to the big ones. Let's start with the lateral cord.
Lateral cord, C5, C6, B7 gives 3 main branches. Lateral pectoral nerve to pectoralis major. The musculocutaneous nerve, a major terminal branch supplying all the anterior arm muscles, biceps, brachialis, coracobrachialis, and then becoming sensory for the lateral forearm. And the lateral root of the median nerve.
Okay, medial cord.
Medial cord C8T1 gives 5 branches. Medial pectoral nerve to pectoralis minor and major. Medial cutaneous nerve of arm, sensory. Medial cutaneous nerve of forearm, sensory. The medial root of the median nerve, which joins the lateral root. And the other major terminal branch, the ulnar nerve.
Ulnar nerve comes from the medial cord. Got it. Supplies.
Yeah. Ulnar nerve supplies flexor carpi ulnaris and the medial half of flexor digitorum profundus in the forearm, then most of the intrinsic muscles of the hand, and sensory to the medial hand.
Okay. And the biggest one, the posterior cord.
Posterior cord, C5T1, gives off several branches to posterior shoulder muscles. Superior and inferior subscapular nerves, to subscapularis teres major, and the thoracodorsal nerve, to latissimus dorsi. Then it's 2 major terminal branches. The axillary nerve, to deltoid teres minor and skin over the shoulder, and the radial nerve.
Radial nerve, the really big one.
Largest branch of the plexus. It supplies all the posterior muscles of the arm, triceps, and forearm, all the extensors, plus provides sensation to the posterior arm, forearm, and dorsolateral hand. It's huge.
So understanding this plexus is vital for figuring out nerve injuries. How do clinicians test this? You mentioned dermatomes versus peripheral nerve fields earlier.
Yes, a critical distinction. Dermatomes are areas of skin supplied by a single spinal nerve root. C5 dermatome is the upper outer arm, C6 the thumb side, C7 the middle finger, C8 the pinky side, T1 the inner elbow area. Testing sensation in these zones helps pinpoint problems at the spinal cord or nerve root level, like a disc herniation pinching C6.
So dermatomes test the root level.
Exactly. But if you damage a peripheral nerve further down, say the ulnar nerve at the elbow, the pattern of numbness will follow the distribution of that specific nerve, not a single dermatome. The ulnar nerve carries fibers from C8 and T1, but its sensory patch on the pinky and ring finger is distinct from the C8 or T1 dermatome alone.
So the peripheral nerve map is different from the root map.
Precisely. testing sensation in the specific patch supplied by the median nerve, lateral palm fingers, versus the ulnar nerve, medial palm fingers, versus the radial nerve, back of hand, helps localize lesions to those individual peripheral nerves, which is essential for diagnosis and treatment. You need to know both maps.
Very clear. And given how these nerves travel, especially the big ones like radial and axillary, are there spots where they're particularly close to bones and vulnerable to fractures?
Absolutely. 3 classic danger zones involving the humerus.
Okay. Number 1.
The axillary nerve. It wraps tightly around the surgical neck of the humerus. Fractures there put it at high risk, potentially paralyzing the deltoid muscle.
Number 2.
The radial nerve. It spirals around the mid-shaft of the humerus in the radial groove. Mid-shaft fractures are notorious for damaging it, leading to a wrist dry.
And number 3.
The ulnar nerve. It passes directly behind the medial epicondyle at the elbow, the funny bone. Fractures or even just dislocations here can easily injure it, causing problems in the hand. Knowing these critical nerve-bone relationships is fundamental.
Okay, we've got the wiring sorted. Now for the plumbing, the supply lines, the arteries bringing oxygenated blood in, the veins taking used blood out, and the lymphatics handling fluid balance and immunity. Let's start with the arterial supply. Sounds like a continuous pipe changing names.
Pretty much, yeah. It's one main vessel flowing down, but its name changes as it passes through different regions. It starts as the subclavian artery up under the clavicle. As it crosses the outer border of the first rib, it becomes the axillary artery.
Axillary artery through the armpit.
Right, and it's conveniently divided into 3 parts based on its relation to the pectoralis minor muscle, which crosses over it.
3 parts, each giving branches.
Exactly. The first part, proximal to pec minor, just gives off one small branch, the superior thoracic artery. The second part, behind pec minor, gives 2 important branches. The thoracoacromial artery, which pierces the fascia and branches widely to the pectoral region, shoulder, and clavicle, and the lateral thoracic artery, running down the side wall, important for breast supply in women.
Okay. And the third part, distal to pec minor.
This part gives off 3 key branches before the axillary artery becomes the brachial artery. First, the subscapular artery, its largest branch, which supplies the back wall of the axilla and divides into the circumflex scapular and thoracodorsal arteries. Then, 2 arteries that wrap around the humerus's surgical neck, the smaller anterior circumflex humeral artery and the larger posterior circumflex humeral artery. The posterior one travels with the axillary nerve through that quadrangular space. These 2 anastomos connect around the surgical neck.
Anastomos, meaning they join up, creating backup routes.
Precisely. Collateral circulation. Very important. As the axillary artery passes the lower border of the teres major muscle, it becomes the brachial artery.
The main artery of the arm.
The main one, yeah. Runs down the medial side of the arm initially, then crosses to lie medial to the biceps tendon in the cubital fossa. This is the artery you use for blood pressure readings.
Branches in the arm.
Its biggest branch is the profunda brachii artery, deep artery of the arm, which dives posteriorly with the radial nerve to supply the triceps. It also gives off ulnar collateral arteries that help form anastomoses around the elbow and nutrient arteries to the humerus bone itself. Then, in the cubital fossa, it divides into its 2 terminal branches for the forearm.
The radial and ulnar arteries.
Exactly. The radial artery runs down the lateral thumb side of the forearm. Distally, it becomes superficial, just lateral to the flexor carpi radialis tendon. That's the spot for taking the radial pulse. It then curves around the wrist dorsally through the anatomical snuff box, heading into the hand.
And the ulnar artery.
Usually the larger of the 2. Runs down the medial pinky side, mostly deep between muscles. It emerges near the wrist, just lateral to the pisiform bone, runs superficial to the flexor retinaculum, and is the main contributor to the superficial palmar arch in the hand.
Do they give off major branches in the forearm?
Yes, both give off recurrent branches that loop back up to join the elbow anastomoses. The ulnar artery also gives rise to the common interosseous artery.
Interosseous, between the bones.
Right. This common trunk quickly splits into the anterior interosseous artery, running down the front of the interosseous membrane supplying deep flexors, and the posterior interosseous artery passing through the membrane to supply the extensor muscles in the posterior compartment.
Okay. And how do the radial and ulnar arteries supply the hand itself? You mentioned arches.
Yes, they form 2 interconnected arches in the palm, providing excellent collateral circulation. The superficial palmar arch lies more distally, across the palm, roughly level with the base of the extended thumb. It's formed mainly by the ulnar artery, completed usually by a small branch from the radial artery. It gives off the digital arteries to the fingers.
Superficial arch, mostly ulnar. And the deep one.
The deep palmar arch lies more proximally, deeper in the palm, between the metacarpals and the long flexor tendons. It's formed mainly by the radial artery after it curves around the wrist, completed by a deep branch from the ulnar artery. It gives off metacarpal arteries and connects to the superficial arch. The radial artery also directly gives off the main arteries to the thumb, princeps pollicis, and the radial side of the index finger, radialis indicis.
So lots of connections. These arterial anastomoses sound crucial.
Absolutely critical safety feature, especially around the shoulder and elbow. There are extensive networks linking branches of the subclavian, axillary, brachial, suprascapular, circumflex arteries. It means if one main vessel gets blocked or injured, there's often enough collateral flow from these connections to keep the limb supplied with blood, a vital backup system.
Brilliant design. Now let's trace the blood back. Venous drainage, superficial and deep systems.
Correct. The superficial veins are the ones you can often see under the skin, and they're important for drawing blood. The two main ones start from a network on the back of the hand. The cephalic vein runs up the lateral thumb side of the forearm and arm, then dives deep near the shoulder to join the axillary veins.
Cephalic lateral.
The bathylic vein runs up the medial pinky side of the forearm, then moves onto the front of the arm. About halfway up the arm, it dives deep to join the brachial veins and become the axillary vein.
Basilic medial and the one in the elbow crease.
That's usually the median cubital vein, a prominent connection between the cephalic and basilic veins right in the cubital fossa. Very common, accessible site for venipuncture.
Okay. And the deep veins?
They generally run alongside the arteries, often in pairs,
Yeah.
vena comitatus. So you have radial veins, ulnar veins, brachial veins, all eventually draining into the axillary vein, then the subclavian vein heading back to the heart. They carry the bulk of the blood, especially from muscles.
Got it. Finally, the lymphatic system, the cleanup crew and immune network. Where does the upper lymph drain?
Almost all lymph fluid from the entire upper limb drains into the axillary lymph nodes, located in the armpit.
So they're a major collection center.
It's huge. And they don't just drain the arm, they also filter lymph from the chest wall, including about 75% of the breast, the upper back, shoulder, lower neck, even the upper abdominal wall. This makes them incredibly important clinically, especially regarding infection spread and cancer metastasis, particularly breast cancer.
Are these nodes organized in any way?
Yes, they're grouped into about 5 main clusters based on location, which helps in clinical assessment. There are humeral, lateral nodes near the axillary vein, getting most arm drainage. Pectoral anterior nodes near pec minor, draining chest, breast, abdomen. Subscapular, posterior nodes on the back wall, draining back and shoulder. These 3 groups drain into the central nodes deeper in the axillary fat. And finally, the apical nodes, right at the top of the axilla, receive lymph from all the other groups, plus some direct drainage.
And where does it go from the apical nodes?
Efferent vessels from the apical nodes join to form the subclavian trunk, which then empties into the large veins at the base of the neck, returning the filtered fluid to the bloodstream. It's a vital system for fluid balance and immune surveillance.
Okay, we've built this incredibly detailed picture of the upper limb bones, joints, muscles, nerves, vessels. To truly master this, we need to connect it to the real world, clinical applications, and surface anatomy. This is where that detailed knowledge becomes powerful. Let's start with some common injuries and pathologies.
Absolutely. This is where understanding the anatomy pays off. Let's talk fractures. The humerus, as we discussed, has key weak spots: the surgical neck, high risk to the axillary nerve, and posterior circumflex humeral artery. The midshaft, danger zone for the radial nerve and its groove. Anatomical neck fractures are less common.
Right, what about the collarbone?
Clavicle fractures are very common, especially in the middle third, often from falling on an outstretched hand or shoulder. Medial or lateral end fractures are less frequent. In the forearm, fractures often involve both bones. Classic patterns include Matetius fracture, that's a fracture of the ulna, with a dislocation of the radial head at the elbow, and Galeazzi's fracture, a fracture of the radius with subluxation or dislocation of the distal ulna at the wrist.
Monteggia ulna, Galeazzi radius. Got it. And wrist fractures.
The most famous is Colles fracture, a break of the distal radius, usually from falling on an outstretched hand, where the broken end gets pushed backwards, creating a dinner fork deformity. Very common.
And the small carpal bones. Can they cause big problems?
Nice. The scaphoid is the most frequently fractured carpal bone. Its blood supply often enters distally, meaning a fracture across its waist can cut off blood flow to the proximal part, leading to a vascular necrosis, bone death. This can cause long-term wrist pain and arthritis. Similarly, the lunate can undergo a vascular necrosis, a condition called Kinbock's disease. Both highlight the importance of specific blood supplies.
So tiny bones, big consequences if blood supply is cut. What about joints popping out dislocations?
The sternoclavicular joint can dislocate, anteriorly or posteriorly. Posterior is dangerous because the clavicle end can press on major vessels or the trachea and the neck. The acromioclavicular AC joint dislocation is a shoulder separation, graded by how badly the ligaments, especially the coracocavicular, are torn.
And the main shoulder joint.
The glenohumeral joint is the most commonly dislocated major joint in the body, precisely because of its mobility-stability trade-off. Anterior dislocations, specifically anteroinferior, are by far the most common, often tearing the labrum, a Bankart lesion, and stretching the capsule, making recurrence likely. Axillary nerve injury is a common complication.
Okay.
Posterior dislocations are much rarer.
Okay. And problems with the muscles holding it in place, the rotator cuff.
Very common source of shoulder pain. Impingement syndrome occurs when the supraspinatus tendon gets pinched under the acromion, especially during overhead movements. This can lead to inflammation or tendinopathy, sometimes with calcium deposits, calcific tendinitis, and eventually tears, partial or full thickness can develop, especially with age or overuse. Supraspinatus is the most commonly affected.
And the bursae around there?
Subacromial bursitis, inflammation of that bursa between the supraspinatus tendon and the acromion, often goes hand in hand with rotator cuff problems, causing significant pain on movement. Moving to the elbow, epicondylitis is common inflammation at the muscle origins. Lateral epicondylitis is tennis elbow, affecting the extensor origin. Medial epicondylitis is golfer's elbow, affecting the flexor origin. Both are overuse injuries.
And that one in kids? Pulled elbow.
Yes, radial head subluxation. Happens when a young child's arm is suddenly pulled. The radial head slips partially out from under the annular ligament, which is still relatively lax in young children. Painful, but usually easily fixed by a clinician.
Okay, let's focus on the nerves again. Nerve entrapments and palsies. These can be really debilitating.
Hugely impactful. Severe brachial plexus injuries, say from a motorcycle accident, can cause devastating loss of function in the entire limb. Depending on the force, you can get injuries to the roots, trunks, or cords, each with different patterns of paralysis and numbness.
Specific nerve examples. Winged scapula.
Winging the scapula is classic. Damage to the long thoracic nerve, which runs superficially over the ribs, paralyzes the serratus anterior muscle. Without that muscle holding the scapula flat, its medial border lifts off the back like a wing, especially when pushing against a wall.
And the axillary nerve again, besides fractures.
It can rarely get compressed in the quadrangular space by muscle hypertrophy or scarring, quadrangular space syndrome, causing deltoid and teres minor weakness and sensory loss over the shoulder.
What about the ulnar nerve? Down at the elbow or wrist.
The ulnar nerve is very commonly injured, most often at the elbow in the cubital tunnel, behind the medial epicondyle, or at the wrist in Guyon's canal. Injury leads to the characteristic ulnar claw hand, hyperextension at MCP, flexion at IP joints, especially ring and little fingers, wasting of hypothenar muscles, weakness of finger abduction, and sensory loss on the medial side of the hand. Testing sensation on the back of the hand helps distinguish elbow versus wrist lesions.
And the median nerve, carpal tunnel, is the big one.
By far the most common site for median nerve problems is compression in the carpal tunnel at the wrist. Classic symptoms are tingling numbness in the thumb, index, middle, and half of the ring finger, often worse at night. Eventually, you get the thenar muscle wasting, that thumb mound shrinks, and weakness of thumb abduction and opposition. Importantly, sensation over the ulnar eminence itself is usually spared because the nerve branch supplying that skin comes off before the tunnel. This helps differentiate it from higher median nerve lesions, like rare compression by the ligament of Struthers in the arm.
And the radial nerve, wrist drop.
Radial nerve injury, typically from compression in the radial groove, mid-shaft humerus fracture, or Saturday night palsy, classically causes wrist drop. That's paralysis of all the wrist and finger extensors. You also get sensory loss on the back of the arm, forearm, and hand. Injury to its deep branch, the posterior interosseous nerve, lower down, can cause finger drop, but might spare wrist extension if ECRL, ECRB are spared.
Okay, crystal clear links between anatomy and nerve function. What about vascular clinical applications? Using our knowledge of arteries and veins.
The anastomoses are key. If someone cuts the radial or ulnar artery at the wrist, the hand usually survives because the other artery in the palmar arches provide collateral flow. A first rib fracture might threaten the subclavian axillary artery, but again, scapular anastomoses offer protection. However, an anterior shoulder dislocation can compress or tear the axillary artery, requiring urgent repair. We also see avascular necrosis of the scaphoid or lunate due to their tenuous blood supply.
And for procedures, dialysis, blood tests.
Very relevant. A dialysis fistula surgically connects an artery, radial or brachial, to a vein, cephalic, to create a high-flow vessel for easy access. Venipuncture relies on accessible superficial veins like the median cubital or cephalic. Blood pressure uses the brachial artery. Allen's test checks the connection between radial and ulnar arteries before using one, ensuring the hand will still have blood supply. Central venous access via the subclavian route often actually targets the axillary vein just below the clavicle, and imaging like ultrasound or angiography visualizes these vessels non-invasively or with contrast.
So many direct applications. What about other clinical considerations? Breast cancer? Nerve blocks?
Breast cancer is highly relevant because lymph drainage goes to the axillary nodes. Surgery or radiation there can disrupt lymphatic flow, leading to chronic arm swelling, lymphedema. For surgery on the arm or hand, a brachial plexus nerve block numbs the whole limb by injecting anesthetic into the axillary sheath around the plexus and artery, allows awake surgery.
And simple nerve tests.
We can quickly test nerve function. Shrug shoulders, accessory nerve trapezius, touch thumb to pinky, median nerve opposition, spread fingers against resistance, ulnar nerve interossae, extend wrist fingers against resistance, radial nerve extensors, quick screens.
And that finger extension trick.
Right, pressing your middle phalanges flat immobilizes extensor digitorum. You can still extend your index and little fingers using their dedicated extensors, extensor indices, extensor digiti minimi, showing independent control.
Cool. Other hand issues.
Things like trigger finger, tendon sheath tightening, Dupuytren's tenosynovitis, inflammation of thumb extensor tendons at the wrist, and Dupuytren's contracture, palmar fascia thickening causing finger flexion, are all common conditions affecting hand function, rooted in the anatomy we've discussed.
Okay, last piece. Actually navigating the surface. Finding these structures by feel or sight. Key anatomical landmarks.
Crucial skill. You can palpate, feel, many bony landmarks. The entire clavicle, the spine, acromion, and coracoid process of the scapula, the humeral epicondyles, the ulceranon, the radial and ulnar styloid processes at the wrist, the pisiform bone, hook of Hammett, scaphoid trapezium tubercles. These give you your bearings.
And tendons and muscles.
You can feel or see prominent tendons at the wrist, flexor carpi radialis, next to radial pulse, palmaris longus if present, flexor carpi ulnaris. On the back, the extensor tendons, muscular contours like the trapezius slope, the deltoid bulge, the brachioradialis mass on the lateral forearm, and the narha pulmonar eminences in the hand are all visible or palpable, and changes can indicate pathology.
Visualizing the axilla. Finding arteries.
You can see the axilla's anterior and posterior folds for artery palpation, axillary artery high in the armpit, brachial artery mid-arm medially, relating cubital fossa medial to biceps tendon, radial artery at the wrist lateral to FCR tendon, and in the anatomical snuff box, ulnar artery is tougher near the pisiform.
And the anatomical snuff box itself. Define its borders again.
It's that triangular hollow on the back of your wrist at the thumb base, clearest when you extend your thumb. Medial border is the extensor pollicis longus tendon. Lateral border is the abductor pollicis longus and extensor pollicis brevis tendons together. Floor is the scaphoid and trapezium bones. Radial artery runs right through it. Tenderness here suggests a scaphoid fracture.
Okay. And locating the palmar arches.
Roughly, the superficial palmar arch is level with the distal edge of your fully extended thumb across your palm, near the proximal palmar crease. The deep palmar arch is about a finger width, more proximal, closer to the wrist. Knowing these surface relations helps you visualize the underlying structures. It connects all the dots. Hashtag tag outro.
Wow. That was truly a deep dive. We've covered an incredible amount of detail about the upper limb. It's just staggering, the complexity.
It really is, from the tiniest bones in the wrist to that intricate brachial plexus network, the layers of muscles. It's a marvel.
And seeing how it all connects, the structure, the function, the clinical relevance, it really gives you an appreciation for it, doesn't it?
Absolutely. Understanding how each part contributes, how the nerves control the muscles, how the vessels supply it all. It moves from just memorizing names to truly understanding the system, achieving that professional level grasp.
And that's what we aim for here at the Deep Dive, to equip you with that deeper understanding so you're not just learning facts, you're mastering the information. You can now look at the upper limb, understand its movements, and even interpret clinical signs with, well, a much more expert eye.
Exactly. So next time you pick up a pen, throw a ball, type an email, maybe just wave hello, take a second to appreciate the incredible biological engineering at play.
Yeah. This limb that can deliver immense power one moment and execute the most delicate, precise task the next. It's truly extraordinary.
It really makes you think, doesn't it?
Hmm.
What other parts of our body, things we might take for granted, hold such intricate secrets and amazing capabilities just waiting to be explored?
A perfect thought to end on. There's always more to discover. Join us next time for another deep dive.